Thank you, Dr. Dhiman. Thanks, Dr. Rella and the team, Joy. For the first time, I feel hepatology is as good as endoscopy. The hall is full. We have so many people. Congrats, Mohammed. I'll try and share with you some concepts. First, the tribute. Because of these residents who come across the country I work, and all the young faculty smarter than me, better than me work at the institute. I bring greetings. I'll start with a case. 58-year male, bleeder, small varices, ALD decompensated, MELD 18, sodium 924. Needs a tap every week and has cough and was on moxifloxacin. The patient was referred for transplant, but the options were very doubtful. His baseline was low hemoglobin, borderline urea, and a sodium of 127. He was on toracamide 20 spironolactone and was receiving albumin every week. On day 7, on a follow-up in the outpatient, we realized his create was going up, sodium was dropping. We had stopped the toracamide, spironolactone was decreased by the resident, should have stopped actually, and albumin was mailed alternate day and he was tapped. Now, again in the outpatient we realized this guy, create is going up, bilirubin was going up, and his sodium had dropped. He was now receiving daily albumin, thirdly was started. The question was, do we need tips to optimize, or does he need a transplant on priority? But he says he has to wait, and that's what a hepatologist comes into play. How common is the problem? The recent issue, even in pediatrics in hepatology, the next issue will show you that in pediatrics also below 1 year and even below 5 years, this is a common problem. I could get some data of till 2012, about 3,200 patients which we saw at the Liver Institute. Create was high in about 447. Those who had a high create, mortality was higher than those who had a create was within normal limits. But this may include some AKI as well. Ascites, you all are very senior people. These are old definitions. None of us can reach 400 of spironolactone or furosemide of 160. Lack of response is if you don't lose enough weight, or when you have early recurrence, that is grade 2 or 3 ascites within 4 weeks of initial mobilization. You know all refractory ascites which cannot be mobilized or reaccumulates after LVP on a low sodium diet, and the inefficiency of diuretics to improve urinary sodium output or diuretic related untoward effects. So you can't give it. What does diuretic do? And that's what this patient came us with. This can lead to HE, so please keep a watch. Don't spoil the transplant chances of the patient. It can increase your create fast, as it occurred in our patient in 2 weeks. Sodium dropped, it can drop. Hypo or hyperkalemia can occur, and it may lead to a hypervolemic hyponatremia. Patient is already sarcopenic, there is no mass with him. It has a survival of only 50% for 6 months. How much time you have? You have to optimize, you have to mobilize all resources. You have to avoid drugs, aminoglycosides, NSAIDs, and of course any acute and chronic liver failure, any insult in that patient, and avoid hernia surgery and all that, because that might create a problem. Now I'll give you some basic concepts which I'm sure you know, but I'll share some new ideas on this. The mean arterial pressure in a healthy guy, cirrhotic with no HRS and with HRS, the pump is failing. Cardiac index initially improves, then it starts failing. So that's a simple cartoon diagram of a normal guy, central blood volume and a good heart, gives good abdominal circulation, good renal circulation, good periphery. But in a cirrhotic with hepatorenal, you have a dilated system which is underfilled, heart output is more, it tries and tries, and you have more blood going to splanchnic, less blood is going to the kidney, and to manage that you have stimulation of ADH, catecholamines, renin and angiotensin. Now you realize this vasodilation, increased circulation lack here is a problem which is for years together, months to years. Now this is the autoregulation has not shown. It's a beautiful diagram. In a normal guy with a renal perfusion pressure like your pump, 25 is enough to give you, 25 millimeter is enough to give you renal output. But in a kidney guy with a hepatorenal cirrhotic, you require 75 to 100 ml per minute to make that pump so that the renal perfusion takes place. So 3 to 4 times more regulation is needed. Let me give you know all this. In a cirrhotic, you have increased cardiac output, you have vasodilation, and now you have a patient who gets infection. Our guy has moxiflux. He may have endotoxemia, SIRS, he is already on beta blockers, he needs TAP, so he is on aggressive paracentesis. You further decrease the intravascular volume, and now this guy may have diarrhea, dehydration, you are giving him lactulose all the time, making him hyperkalemic. Activation of neurohormonal system, it will lead to further vasoconstriction and starts the process of sodium, water and retention of these. Ascites comes. Now he has a pain, he gets NSAIDs, renal perfusion further goes down, there is no response to fluid challenge or even albumin, he gets hepatorenal. Here there is a high cardiac output, then he goes to low cardiac output, he is on beta blockers, and he really has some evidence of SIRS and sepsis. How do you optimize this guy? When he has vasodilation, we have options. Turley was very popular till few months ago. Now noradrenaline is coming back in a big way. Turley has more side effects. It hasn't got the FDA approval. So NORAD, which one of our group residents had shown much earlier, is very effective. Octreotide, midodrine is in a big way coming back. The aim is to keep MAP above, mean arterial pressure above 70. You need albumin here for retention of sodium, water, decrease water intake and salt intake. You may do large volume paracentesis and you may need albumin. The question is, what are the other effects of albumin other than making the intravascular compartment, the colloid, better? I'll come to it in a minute. So PICD, I am sure you are aware of it. When you have renin activity going more than 50% of baseline on day 6, we start doing it at day 1 and 3 as well. If no albumin and you still do TAP, you have not done the plasma expansion, PICD can be in 3 out of 4 patients. So please do not do TAP without an albumin. What it can lead to a hyponatremia which will persist. You have done 4 TAPs, his sodium is 120, won't recover for months, and he may land up with HRS. What does albumin do? This is a rat study by Pavlov, but it shows you the red is cirrhotic. The left ventricular diastolic pressure here and a control is very good, pumping. We had a good cardiac evaluation done. When you give albumin, the cardiac and diastolic pressure improves. It becomes nearly normal. What albumin does is provide oxygen, provides the cardiac contractility back, but always do an echo before giving albumin. When you give starch, nothing really happens. So albumin has other than vascular effects. So when you have a patient who has a kidney problem like our patient, you do albumin alone, not enough. Then you do Turley and albumin, the probability of response is about 50 to 60%. And therefore, when you do albumin, Turley and the TAP together. Our patient also has low sodium. He has less than 120. Come for transplant setup, I would say 50% of them would have a low serum sodium. The patients who have low serum sodium and have ascites will have child C, more of renin, more of aldosterone, more of adrenergic drive, NORF will be high. But this is an important slide. severity of cirrhosis and retention, but renal oxygen consumption in child C is much higher, though GFR doesn't improve. As I showed you earlier, you require more pressure and you require more oxygen, which is not there. What does it lead to? In a cirrhotic, you have decreased systemic vascular resistance, so you need to have effective arterial hypotension, it has to be managed. But what it leads to is decreased arterial blood volume, non-osmotic arginine vasopressin hypersecretion. On the systemic circulation, arterial vasoconstriction pressures go up, but on kidney side you have tubular water reabsorption, but more important and bad is solute free water retention. It leads to hyponatremia, which is hypervolemic. And what you can do is try and use Veptans to some extent, prioritize for liver transplant. Our patient coming back, we stopped diuretics, he was on Turley. Will Turley lead to hyponatremia? Possibly yes, especially in an acute setting. Therefore, Turley also is one which can add to hyponatremia. If the patient has received because of some drugs and acetylcysteine with dextrose will lead to hyponatremia. Moxiflox, our patient was on moxiflox, also leads to severe hyponatremia. So we had to stop mox and remember that we should not use such drugs. So back to our patient, ascites grade 3 had poor response. We tried LVP, albumin, Turley. We didn't try aquaretics because he had bled in the past. So we were left with options of TIPS and transplant, and we have to optimize him for 3 months. Can you take him right away? Suppose there was a donor available. Even then it is advisable, correct sodium and create if possible, so that your post-transplant scenario is better. He had 105 sodium and you transplant and give him a new liver. There is a possibility that he may have some problem with the kidney. May not be, there is not enough data, but there is a possibility. Prevent renal dysfunction by giving TIPS. Should we do TIPS in a patient prior to transplant? Now he has 3 to 6 months, he doesn't have a donor. What do we do? And second scenario is he has no option for transplant. Should we continue with Veptans or TIPS? So let me show you something on Veptans which you know, and it is available in India. These are drugs, arginine vasopressin, as I showed you, receptor which causes retention. So they block this receptor, especially the V2 receptor. So you have lumen of the collecting duct and you have blood. Arginine vasopressin, what it will do, which is over secreted now, will make the receptor move to this side, the aquaporin receptor. Water which should have gone out is taken back and it is not allowing this to go out. What Veptans will actually do is block this, and therefore you will have the water, in simple terms, going out into the lumen and pure water, aquaretic property of these Veptans. Tolvaptan when used as compared to placebo, Tolvaptan and here and the placebo, in about 5 days time compared to placebo, serum sodium started improving very rapidly. And what you need is 5 to 7 milliequivalent per day, not more than that. That can create a problem, but it has side effects. 1 in 3 will have thirst, asthenia, polyuria. It decreases the vitamin K dependent factors. So variceal bleed is a high risk. So if you have a patient with high risk varices, don't try this. Worrisome is central pontine myelinosis, and the risk factor would be that such a patient who has low sodium or hypokalemia or alcoholism, all of that in our patient possible, and malnutrition and advanced liver disease, and now you give Veptan, you may really have a high chance of CPD. So therefore remember, the second option in our patient would be, if he can afford and if he is fit, he had a bill of about 2.2. So in that particular scenario, bilirubin of 2.2, TIPS can be an option. What will TIPS do? TIPS will actually decrease ascites production, drainage will be better, and effective arterial blood volume will be better. You all know this, and this study by Dr. Sanyal, which showed that compared to conventional medical therapy, TIPS actually can give you good 3 to 6 months time, may improve actually survival. We have done about 120, majority of them are in ascites patients or HVOTO. What TIPS does? This is very beautiful work with Martin Rossell, and I want you to pay attention to this. This is a meta-analysis, 7 studies, 8 studies, 3 or 2 studies, and a follow-up up to 1 year. In 1 to 3 weeks, urinary sodium excretion, as you can see, at 1 to 3 months, so urinary sodium continues to increase, and in fact, after some time, it can even be higher. So it's a good system for it. Serum creatinine levels keep going down. Even at 6 months, you have sodium create coming down. Plasma renin act very high used to be. It starts coming down and maintains for 1 year or so. Aldosterone comes down and maintains. NORAD levels come down and gets maintained. So it's actually more physiological than doing just TIPS. Hemodynamics, cardiac output. Before TIPS, 5 minutes after TIPS, you can see that, and over 12 to 14 months. The cardiac output, the pump function improves, peripheral resistance, as you say, has improved in these patients. So this was pre-TIPS or at post-TIPS, and finally cardiac output has stabilized, your SVR has improved, so you are less vasodilated, and it also improves your muscle mass, your weight, body mass, fat decreases, energy expenditure improves, and energy intake improves. So TIPS in a way is good to optimize your patient, make him better for a transplant. Does it improve 2 years survival? 2 studies, Martin's and Salerino's studies, both show significantly improved survival post-TIPS. Now, will this patient be good for TIPS or not? Our patient had a platelet of more than 1 lakh or so. Platelet count more than 75 or bill of less than 50, that's about 3. So if you have good platelets, low bilirubin, you have a better survival. In fact, 12-month survival could be 75% or so. But if your platelet counts are low and your bilirubin is this, then your survival is poor. Our patient, he had pre-TIPS bilirubin, 2.9. He went for TIPS, and day 7 bilirubin went up, and post TIPS 2 months his bilirubin is still 3.3. His sodium is 127. It improved slowly. He went on TIPS on 4th of September last year. The gradient was 22, it's come to 11. He still needs albumin, and he still has a need for terlipressin. What do you do? That's a challenge. So my carry home message for this patient, which is a representative of most what you see, a swollen recipient who had hyponatremia, has 3 months to 6 transplant. I gave you a scenario post TIPS 2 months. What will happen in next 1 month? We don't know. So he has refractory ascites, low sodium. We tried to optimize by giving LVP. You can have Turley, you can have NORAD, you can combine midodrine with octreotide, and definitely need albumin. You can give a short course at the most of a week of tolvaptan if his sodium goes below 120 or so. Yes, I would say one can optimize him by TIPS, and if he needs especially 2 LVPs a month, ours needed 1 LVP every week, and this should not go beyond 3 months. If you treat him by TIPS, he may live through 30% of the chance, but I think he will need a transplant 70%. So our patient would fall into 70%, and I think we need to optimize him, and we have done optimized for liver transplant. Is the question remains, is a patient who has got a TIPS, is he worse for a transplant or not? I leave for the surgeons, but in my opinion not. Thank you for your kind attention.
Thank you, sir, for that excellent talk. Any questions from the audience?
That was a wonderful talk. You come from a perspective of living donor liver transplantation. I think I would like Professor Deirdre Samuel, maybe Susan, to get up and answer some questions. The problem of cadaver that you see in the West is, I have seen, you touched upon it, I have seen a patient with central pontine myelinolysis. It's a disastrous complication after liver transplant, and that comes from transplanting patients with low sodium. In the cadaver setting, you admitting a patient who's very sick, and he's come in and the organ's gone to retrieve, somebody's gone to retrieve the organ, and you get the sodium back as 118, and you probably got 12 hours, do you say that we will not carry on with this operation, or is there something you can do within that 12 hours? The answer to hepatologists and intensivists.
No, I think that indeed, as said by Professor Sarin and you, I mean, when you consider a living donor transplantation in contrast to a cadaveric donor, you can choose the day of the transplantation. And I think this is, for living donors, this is, I think, an advantage. And I agree fully with Professor Sarin. You have to improve your patient before to perform the transplantation. And indeed, if you do the transplantation when the natremia is below 120 or 110, you may indeed have a risk of Sarin-Pontine myelinalysis. So you may improve the renal function. I mean, the TIPS procedure is an excellent procedure. I mean, to improve nutrition of the patient in HRS type 2 patient or in patient with this type of chronic hypovolemia and renal failure. I think so I agree that the setting on LDLT, living donor transplantation, is different from what we see in Europe, where, I mean, in contrast, I mean, the point is that in the last year in Europe and in US, is that everything is driven by the MELD score. So, for cadaveric donor. So, higher your MELD is shorter is the waiting time for the transplantation. But the risk...
Admitted a patient in hospital with a sodium of 118. What is your message to people? You won't do the transplant and get another patient, or is there anything you can do in that 12 hours you have to make him eligible or make him transplantable?
No, you cannot do it in 12 hours. You need several days. So I think
you will send the patient home?
No, I will try to improve the patient in hospital.
No, this is a cadaver organ allocated to him.
Ah, yes.
I'm talking about, this is not about live donor. Live donor, we agree with everything Dr. Sarin says, and we've got the time to get them better. You postpone the operation by a week. And he may not get another organ.
No, it's not, I mean, the way the organs are given now in France, I mean, for example, the MELD score is valid, you can use the MELD score during 3 months. So I mean, if the patient is very severe and a high MELD score, I think you can wait several days to improve the patient. If you do it, you will improve your patient survival after the transplant, and he will not lose his chance.
So what is your cutoff for sodium to send a patient back home, or to admit him and correct it and turn away the organ donor for that patient? What is your cutoff for sodium?
I think a patient should be over 120.
Susan, do you have any comment about that?
If we had a patient with a sodium between 118 120, we would not carry on with the transplant. We would get a backup patient in because we feel the risk is too high.
Thank you. I think that's a very clear message now. Thank you very much.